everyone for coming tonight. As I mentioned before, it is really hard to cover everything about cholesterol in one meeting, but hopefully you can just walk away with at least either easing your concerns or knowing what to do if you do have concerns. So I'm going to start off with kind of what is cholesterol, and then talk about what is it that you actually see on your blood work, and then get into am I high risk, or what are the risk factors, and then what to do about it. Okay, and then we'll leave time at the end for questions, but you can stop me as I'm going through this if there's something that you have a question about. All right, so what is cholesterol? So cholesterol is essential to life. I mean, a lot of times cholesterol has a bad reputation, but we need cholesterol. Every cell in our body makes cholesterol. It's a fatty, waxy molecule. I couldn't really find a picture of what really cholesterol looks like, so you get the chemical structure here. But it has a lot of different functions, and we'll go into that. So the first thing here is cell membrane. So if you look at a cell in the body, it kind of has this protective membrane that's around it. And the membrane allows things to come in and come out. It helps it to have fluidity. Like, our cells are not like rigid, hard spheres that are going through our body. You know, they're able to kind of squeeze and expand. And so cholesterol, this is sort of a blowout of this little part of the membrane here. These molecules here are cholesterol. Cholesterol is in every single cell membrane in our body. And so cholesterol is what helps it have that fluidity to be able to move, connect with other cells, be able to get through the blood vessels. So it's extremely, extremely important. It's a building block for steroid hormones, for you to make testosterone, estrogen. All of those are based, cortisol, all steroid hormones, the building block for it is cholesterol. Bile salt synthesis. So I don't know if you've heard of bile, like our gallbladder has bile and helps us digest fats. So cholesterol is part of that whole process of creating bile salts. So on our nerves, there's something that covers our nerves called a myelin sheath. It's like a protective thing. Those are made with cholesterol. And so extremely important for brain health, having enough cholesterol. It's a precursor for vitamin D. So for our body to make vitamin D, we need cholesterol. That's part of this process. Repairing cells, cellular growth, all of that requires cholesterol. So if you look at the brain, it's actually only 2% of our total body weight, but it uses 25% of our cholesterol. So cholesterol is very, very important. And so when we look at things that reduce cholesterol, we want to, keep these things in mind, because when we reduce cholesterol, inevitably we impact a lot of cellular function. All right, so how's cholesterol transported in the body? So when you look at your blood work, everything's abbreviated, right? It says LDL, HDL, but what does that actually stand for? So HDL is high density lipoprotein. LDL is low density lipoprotein. That's actually not cholesterol itself. Cholesterol is carried on lipoproteins. So if you think about it, so cholesterol is a fatty molecule. So you know what happens when you mix oil and water? What happens? It doesn't mix, right? It doesn't mix. So one of the problems is if your body is making cholesterol, and let's just say cholesterol needs to get from the liver to the brain, the quickest way to do that is through circulation, is to transport it in the blood. Well, because blood is predominantly water, cholesterol can't just travel on its own through the blood to get to the brain. So what it does is cholesterol is sort of packaged inside these lipoproteins. So inside this lipoprotein is cholesterol, triglycerides, there's like fat-soluble vitamins, there's some antioxidants, and they all get kind of packaged in this lipoprotein, and the lipoprotein is water soluble. So this can go, it's almost like a boat. Sort of think of it as a boat, and it's carrying cholesterol inside of it as a passenger. And lipoproteins are traveling around in the blood to get to where it needs to go. And once it gets there, it then unloads, delivers triglycerides, cholesterol, vitamins, antioxidants, whatever it is that particular cell needs, at that time. So when you're measuring cholesterol on your blood work, it's really saying how, if I were to take all the high density lipoproteins that have cholesterol and break it down, what would that amount be? And that's sort of the number that is on your blood work. So I just wanted to make that distinction because I think a lot of people don't recognize that number or that description is not just cholesterol. It's the lipoprotein that's carrying cholesterol. And so that's why I wanted to explain this, just to make that distinction so people understood how cholesterol actually is moving around in your body. So there's really only one type of cholesterol, but there's multiple types of lipoproteins that carry cholesterol. So typically what you see in your blood work is you'll see HDL, which they call the good cholesterol. You'll see LDL, which they call the bad cholesterol, and then VLDL. Sometimes, not everyone always has VLDL, but VLDL is another type of cholesterol. So those are the three main ones that you see in blood work. So if you look at it, what's the difference between these different ones? And basically it comes down to size and density. So we know density is like kind of how heavy something is, right? So if something's more dense and you put it in water, it kind of like, sinks, where something's lighter, it's more buoyant. And so HDL is called high density lipoprotein, meaning it's heavier. And the reason it's heavier because high density lipoprotein has more protein in it than it does cholesterol. Since cholesterol is waxy and fatty, what happens usually with fat and water? Right? It's lighter, it flows to the top.
Mm-hmm.
And so if you look at it, LDL, it's a little bit bigger in size, has a little less protein and a little more cholesterol. So it's a little bit bigger just from the fact that it has more cholesterol, but it's also lighter, so it's less dense. And then as you go up, we don't really measure these in blood work. IDL is intermediate density lipoprotein. It has a very short life, so it kind of comes and goes real quick, so you really can't measure it very well. And then chylomicrons is another way of just transporting, but for the sake of heart disease, those are the three main ones. And again, VLDL, same thing. It has less protein, larger in size, more fat, triglycerides in there. It's going to be more buoyant, and that's what makes it less dense. Does that make sense? All that? Okay. So when you get a total cholesterol number on your blood work, what you're getting is the sum of these three things. So individually, when it says, cholesterol is measured as milligrams per deciliter. Like when you look at, if you were to look at the units on your blood work, it would say, let's just say your HDL is 50. It's 50 milligrams per deciliter. That means that they took all the HDL from your blood sample and broke it all out and took all the cholesterol that was inside each of those HDLs, it would be 50 milligrams of cholesterol per deciliter. So that's kind of how, to understand those numbers a little bit better. Any questions so far?
Great explanation.
All right. So as I said before, the lower the density, the less buoyant. So these are actually more buoyant. And like I mentioned before, there's really only one type of cholesterol, but different things that carry those cholesterol. And each of them have different jobs, but just wanted to make sure that you guys kind of understood how that worked. All right, so is LDL actually the problem? And I tried not to get too sciencey, but sometimes it was hard. There's certain terms and things that I kind of have to mention just because that's just what it is. But I'll try to simplify it as much as possible. So there's really no good or bad cholesterol. There's just cholesterol. The problem is when cholesterol can get damaged. And so again, like we said before, it's actually, the cholesterol is inside these things. So this is like the lipoprotein, right? The cholesterol, like we saw before that other picture, it's inside. But on the outside, it has like different proteins and different things. So depending on the environment inside our body, it can get damaged. And when LDL becomes damaged, or they call it oxidized, that's when it becomes problematic. So what are the things that could damage LDL? Have you ever heard of free radicals, that term? So like free radicals are when, let's just say you have a cell and the cell is damaged by some type of, I'll just say sugar. Okay, so sugar kind of messes up the cell, and the cell almost like releases, like byproducts as a result of that damage. That would be like a free radical. So like when you burn a fuel, like let's say you have a campfire, you know, smoke comes off of it. It's almost like when our body burns a lot of sugar, or has a lot of sugar coming in and it's burning it for fuel, it like releases like a byproduct, almost like the smoke that's coming off of a campfire. So that's one thing that can happen. So we have free radicals, it's kind of like smoke or whatever, it's kind of around, sort of impacts and interacts with LDL, that can cause it to be damaged. You also have some, like I mentioned before, there's sugars, like let's just say we have high blood sugar. That excess sugar in the bloodstream can also, when in contact with the LDL, become problematic and oxidize this LDL. So once it's damaged, now the body's got to sort of deal with it and figure out how to get rid of it. And one of the issues is that, you know, our cells almost have little, sort of think of them like little baseball mitts, like stuck around it, right? And it's constantly like catching stuff, bringing it in, or like throwing things out. But these baseball mitts are very specific to certain things. Like this baseball mitt only catches LDL. This baseball mitt only catches, you know, HDL or something like that. When these become damaged, the things that normally would catch it and get rid of it don't recognize it anymore. It's like, hey, oh wait, why does that thing not look like it normally looks? So now it's, you know, because it's been glycated or it's been oxidized, the recognition of it, it's like, oh, it doesn't look the same. That must not be what I'm supposed to catch. So it just kind of lets it continue and stay in, you know, in the bloodstream when it really shouldn't be, or wherever it is in the body that, you know, it needs to go. It may not go where it's supposed to because of the fact that it's oxidized. And why HDL, and that's why they call this bad cholesterol, because it's more likely to be the cholesterol that causes problems. So in and of itself, LDL is not bad. It's when something happens to it that then it sort of becomes problematic. And HDL, they call it good because HDL is one of the things that helps clean up LDL. So that's why HDL is known as being good cholesterol. All right, so this is an extremely simplified way of talking about plaque buildup, but I felt like we needed to discuss this in order to really understand, because this is where a big controversy happens with cholesterol, right? Because everyone's like, oh, you eat cholesterol, if you eat cholesterol, it's gonna get stuck in your blood vessels. You're gonna clog yourself up, you're gonna have a heart attack. Like that's pretty much why everyone says stay away from don't eat eggs all the time, because it's too much cholesterol and it's gonna become a problem. So, but in order to know whether or not that's true, it's good to kind of just understand how plaque actually happens. So I think a lot of people think that you have a blood vessel and plaque just kind of like stuck in here and then builds up. But actually, plaque builds up right underneath the lining of your blood vessel. It's not actually like in here, it's actually under. So this row here, that's called the endothelial lining. It's like a thin layer of cells that line our blood vessel. Okay. So one of the first steps for atherosclerosis, which is basically plaque buildup, one of the first steps is there's some kind of damage that happens in the lining of the blood vessel. And so when that damage is there, and I'll talk about what are some potential things that can cause the damage. When there's damage, what then comes on the scene are immune cells, white blood cells, there's some other cells called macrophages. So these are all cells like when there's damage, like if you hurt yourself, one of the things your body does is, oh, I need to go heal it. So it's the same thing. When there's potential injury, the body sends, white blood cells to that area to kind of take care of it. So the white blood cells come, and meanwhile, this is not in a vacuum. There's things floating around all the time in our bloodstream, specifically LDLs. So LDLs are kind of floating by, and LDLs kind of come almost to sort of like help patch up that injury. So when that happens, and again, if we have potentially things that are oxidizing, we talked about damaging that LDL. So now we have LDL that's being stuck and most likely oxidized LDL if the environment is not great. Then these white blood cells, even more reason say, hey, these LDLs don't look like normal LDLs. So then the white blood cells almost start to attack the LDL, we have cells called macrophages. They start eating up the LDL, and they start to become sort of these big cells here, and you see all the cholesterol stuck inside, and it just becomes more and more, and eventually these macrophages start dying, which causes more immune cells to come and be like, we need to get this under control. There's like all this inflammation happening, all these things are going on. Cells start dying. When they're dying, they're releasing all these inflammatory things. So it's just a big mess. And then ultimately, it just goes more and more. So if you think about it, the reason LDL is a problem is because as it's coming through, it's continuing to just kind of pool into this area. So let's just say that happens. It starts off here. We have a little bit of buildup. The body's able to sort of heal it, and then they're done. And then let's just say now there's another injury that comes on this endothelial lining. So this doesn't happen in one shot. This is a progression over time. So you may have something where there's just a little bit of, of this plaque growth. But then over time, let's say another part is injured again. Plaque comes, the white blood cells come again, oxidized LDL is there. Again, it continues to build and build. And over years, eventually something like this can happen if we continue to have an environment that is oxidizing more LDL and also injuring the endothelial lining. And then eventually over time it becomes so much that there's less blood flow because there's just not enough room, or you could actually have like a clot build up, and then eventually if that ruptures, that's when you have a heart attack. So that's a super simple, it's way more complicated, this whole process, but I tried to just give us a more simplified version of how plaque actually develops. Any questions about that? So one of the things the body does is, as this happens, they call it soft plaque. It's like unstable. It could rupture, it could move, could fall off. So what the body does, then it takes this calcium and it sort of like, almost like a scab, puts a sort of scab over it to keep it in place, so this thing is stable. So when you have calcification, and you find when you do the scan and there's a score, your body has sort of taken that plaque buildup and stabilized it. So it's actually, I don't want to say it's good to have calcium, but at least that is a plaque that's been stabilized. The only way to know if you have soft plaque, which is the plaque before it becomes calcified, is if you do a CT angiogram. Is that right? I think that's the only other test I know of. I think that's the only other test I know to determine soft plaque. Yeah. Any questions about atherosclerosis? Okay. All right. So what are some of the things that actually can cause, well, like we talked about that thin layer of cells that are in the blood vessel, right? And usually one of the first steps of atherosclerosis is some type of injury to the blood vessel. So what are some of the things that can potentially cause that injury? Okay. Hypertension. So that's why hypertension is one of the things you don't really feel per se, and it's just kind of happening in the background, but that pressure in your blood vessels can be damaging. So hypertension is a cause. Elevated glucose, pre-diabetes, diabetes, it's that kind of heading in that direction of the high glucose definitely can be injury to the blood vessel. Obesity, so having excess weight. Hyperlipidemia, so hyperlipidemia means your lipids, which is cholesterol, your triglycerides, they're out of balance. There's something that's not quite right. Maybe there's too much oxidized LDL, maybe you don't have enough HDL to clean up the LDL that's around, maybe your triglycerides are too high. So those are all potential imbalances that can cause damage to the blood vessel. Chronic stress. So chronic stress is very inflammatory, and inflammation drives injury. And so chronic stress can be, although it's not a specific chemical per se, there's a lot of different things that happen in the body when we're under chronic stress. And smoking, alcohol, and cigars, like people are like, oh, I don't inhale. It's like, it's still, it could still be problematic. Again, alcohol is also very well studied to cause injury to the endothelial lining. Aging is just something that just over time, we become more vulnerable to things. So that's not something we can do anything about, but it is part of the problem. And again, anything that causes inflammation or that kind of oxidative stress can be an injury to the lining. Okay, so does eating cholesterol actually increase my cholesterol? Which is usually the one thing that, you know, people tell you, like, don't eat cholesterol. So there's only about 15% of, so if you look at the body and take all the cholesterol that's in here, and that's 100%, only about 15% of that cholesterol in your body comes from the diet. And the reason for that is why it's as small as it is that the cholesterol we actually take in, it's in a form such that it's almost like too big to cross over from our gut into our bloodstream. Some of it is able to get transformed into a version that can get that can come across, but most of it ends up just going through our gut and we poop it out. So the other 85% is made by our body. How I said, every cell in our body makes cholesterol. So for every cell in our body to make cholesterol, it must be really, really important. And so even if you're not eating it, your body will make it. Because like I said, all those different functions that we kind of listed, making hormones, vitamin D, it's in our every cell membrane, repair cells, all those things, your body, your brain, your body needs it, so it's gonna keep making it. So saturated fat can increase LDL, not in everybody, but it can. So saturated fat is different from cholesterol. So there could be cholesterol so like if you eat a food that has saturated fat, that particular food could also have cholesterol, but it's not necessarily dietary cholesterol that makes it increase. For some people, saturated fat can, and I won't go into the science of how the mechanism, if anybody wants to know, I can share with you later. But there's just, remember I talked about those little baseball mitts that are out there that sort of catch things? Saturated fat can sort of decrease how many baseball mitts are on the cells, so less of it's being caught, so more of it is staying in the blood. And so that's one of the mechanisms they think as to why saturated fat increases LDL. It's not so much it increases it by making more, it's just not getting rid of it as well when we eat a lot of saturated fat. Again, it seems to be person specific. Like for some people, like if you hear people going on a ketogenic diet or they're carnivore, you know, and all of a sudden their LDL is so high, it's like, whoa, what's going on? You know, oftentimes it could be related to saturated fat. That may not necessarily be a problem, but if you have to kind of look at other risk factors that you have. So, like I said, LDL in itself is not bad. It's when it becomes oxidized, that's when it's problematic. Any questions on that stuff? Okay, so let's just say my cholesterol is high. Am I at risk? So these are kind of some of the things that you want to be thinking about. What are my triglyceride levels? So ideally you want your triglyceride levels to be under 100, even better under 80. So that's one thing. So if your triglycerides are over 100 and your cholesterol is high, then I think, you know, you need to make some changes.
What's your definition of high cholesterol?
So that's a good question. So I would say if you're high enough that your doctor's like, hey, you need to be watching your cholesterol, then, you know, I would say for most people they're saying that over 200.
Over
your
200.
Total, or
right.
Your LDL being over maybe like, I know in cardiology they want your LDL to be under 100. In some places now even under 70, which I think is ridiculous. But I would say if your LDL is, I don't know, maybe 120 to 150, then, and your triglycerides are also high, like 150 or even higher than that, then you want to say, okay, I need to do something to try to
You're
my
changing the
triglycerides down.
goalposts.
Right.
Yeah.
Because when I was in residency, 160 was high.
For which?
For LDL.
LDL.
Right.
160 and above was. By the time I finished residency, it was 130 or above. And then while I was practicing, it's 100 and above.
Oh my goodness.
And now, like she said, 70.
And I just read an article that they're thinking of moving into 50.
Oh my
What?
goodness.
Yeah.
But what
Wow.
about the HDL? I mean, when
What
they
a
change that, do they
supervisor.
change the HDL?
No.
That's crazy.
Is there a ratio between HDL and LDL that's
Well, so what we like to look at is, we actually like to look at the triglyceride HDL ratio. And so, I think optimally you want that to be 1-to-1 or less than 1, meaning if your triglycerides are 80 and your HDL is 80, that would be a 1-to-1 ratio, right? So you wouldn't want my triglycerides are, 150 and my HDL is 75. So then you'd be like a 2-to-1. So then your triglycerides are a little bit too high. So you want to try to keep that either 1-to-1 or less than 1, where maybe your triglycerides are 50 and your HDL's 75. That's great too. So that you kind of use that. I think triglycerides are totally underutilized in blood work. Like when you go to see your doctor, like they're not talking about your triglycerides much. They're just looking at your total cholesterol number and they're looking at your LDL number, and they're not really paying attention to triglycerides. When we look at what triglycerides are, excess glucose. So triglycerides are generally related to carbohydrate intake. So when we have excess carbohydrate intake, we usually end up having excess glucose. That excess glucose usually gets converted into triglycerides. And so when our triglycerides are going up, it's usually an indication that we have, we're not having the greatest glucose control, or we're taking in too much glucose. Right? And as we said before, high blood glucose is a driver for oxidizing LDL, and causing potentially injury in the endothelium. So, you want to look at that. Okay, if my triglycerides are high, then I'm kind of creating an environment where I'm making it easier for my, the lining of my blood vessels to become damaged. So that's why it's important. Like, am I high? Yes, but are there other things that say, hey, I need to do something to try to turn this around? Another thing that could put you at higher risk is high insulin. So if you get your blood work done, I highly recommend that you ask for a fasting insulin level. Insulin can predict diabetes 10 years ahead. So like we just check fasting glucose. So you may get your blood work done and your glucose always looks fine, like, oh, it's under the normal, it's under 100, oh, I'm fine, it's 90, it's 95. Well, your body's insulin's job is to keep your glucose down. So your glucose could be looking fine, but in the background, your body could be making tons of insulin to try to keep it down. And so once it gets to the point where your glucose is now high, now it's because your insulin's not working well anymore. It's like your body's been producing so much insulin, it just doesn't work well. And so by the time it's high, you already have a problem. So you want to be looking at your insulin ahead of time so you can say, whoa, my body's kind of working overtime to try to keep my glucose under control. Those type of things are red flags that we want to say, okay, that's a potential risk factor. So, checking your insulin, your glucose, the HbA1c, that's kind of like a 3-month running average of your glucose and how you're doing, paying attention to those numbers and take that information along with what your cholesterol is. Do you have hypertension? So if you do have hypertension, that automatically puts you at a higher risk. Is there some extra weight? Smoking, again, alcohol consumption, how much are we drinking on a regular basis? And just overall metabolic health. So if your cholesterol is high and some of these factors apply to you, then I would say, yes, you are at higher risk for cardiovascular issues. With that said, a lot of these things are modifiable, A lot of these things are very responsive to diet and lifestyle. Triglycerides are one of the most responsive things. If you can just kind of cut out some junk, cut out some excess carbohydrates, you can really get triglycerides down. And triglycerides and HDL always work in opposites. So when you get your triglycerides down, your good cholesterol HDL almost always goes up and follows. So they work together very well. Again, cleaning up your diet and stuff, you can bring down your insulin, your glucose. Those are all ones that you can definitely have an impact on. Hypertension, I have seen people who, after losing weight, cleaning up diet and lifestyle, being able to get off blood pressure medicines. So that is definitely possible. There are some genetic components, so some people just have other issues that go on that cause high blood pressure, but if it's related more to diet and lifestyle, I definitely think that can be impacted. Smoking, alcohol, those are all choices that we can make to partake in or not. So I think a lot of these things can be impacted by, just kind of improving our lifestyle.
Is the alcohol,
increasing the cholesterol because of the sugar in the alcohol?
No, the alcohol is damaging the, remember we talked
Oh,
about
right.
the injury?
Oh, right, and that's what the smoking is doing as well?
Yes.
Okay.
So that's why smoking is so related to heart disease, is because of the damage that it causes to the endothelial lining. And the obesity, that's more of just, obesity drives inflammation. And so there's a lot of things that are kind of not working right and out of balance. Also, obesity drives higher glucose, higher insulin. So a lot of these things are kind of connected. So honestly, when you work on focusing to lower your triglycerides, you automatically improve these things. Because when you cut out excess carbohydrates or refined foods, you're automatically gonna lower glucose, lower insulin, and sort of fix that. And then inadvertently, you'll fix excess weight and probably your hypertension too. You know, so they kind of, it can snowball. You can make a lot of changes by just doing a few things. So what if you looked at that list and like, you know what, I'm good, like my triglycerides are good and I feel like I'm pretty good in terms of my risk factors. So they seem low, but my cholesterol's still high. Like, should I be concerned about that? So what I would recommend is you need more than just knowing those few numbers. What's my total, what's my LDL, and what's my HDL. There's something called an NMR lipid profile. So it's a blood test. You just get it when you get your other ones done. But what it tells you is particles, like how many particles I have of my LDL, what size are they? There's different kinds of LDL. Is it the bigger, fluffier kind? Is it the smaller, dense ones, which tend to be more correlated with heart disease? You know, so if my LDL is high, what kind of LDL do I actually have? So it's not really a fair assessment to just say, okay, your LDL's 150, get on a statin. Like, well, what kind of LDL do I have? Maybe I don't even have the LDL that's problematic. So it would be good to have that information before making a decision about what am I gonna do next. So that's called an NMR lipid profile. And any doctor can order that for you, just like regular blood work. But it's just like another deeper level of digging into your cholesterol versus the basics. So a couple other markers to test. There's something called ApoB, which is like the protein that's outside of LDL. So, you know, that's another marker to say, okay, what are those levels? Are they in a high range where this is problematic? Lp(a) is another marker that people test. Again, both of these have been correlated more with heart disease. So if these levels are high, and you kind of do the NMR too, like in combination, okay, maybe these few factors together put me at a little bit higher risk. Again, it's just more information to know about what is the makeup of the cholesterol that you have. For some people, if you are kind of doing higher fat or looking at the composition of the fat you're eating, if it's mostly saturated, you may want to decrease the saturated a little bit, increase more of the monounsaturated, so more of like olive oil and, you know, nuts and things like that, as opposed to fatty meats, you know, something that's going to have more of the saturated fat. And again, I don't think saturated fat is bad, because fat has been demonized inappropriately, but again, it's taking it all in context of what is my current situation, what are my risk factors, I'm doing everything right, LDL still seems higher than it should be, you know, could I make some tweaks to see if I can lower it? And I feel like, you know, tweaking the fat a little bit is something that could potentially lower the number. As we mentioned before, the coronary artery calcium scan. So again, that's to get a baseline of where you are. I think it's good to just assess it, and then based on what your score is, determine how often you would need to get it repeated.